Dear friends and colleagues, I am Dr. Anshul Agrawal. I am working as a consultant endocrinologist in Vinayak Hospital, Jhansi. So today I would like to speak about the novel treatment in the aspect of type 2 diabetes through a case-based scenario. This is the patient AB, which is 53 years old, corporate executive with history of type 2 diabetes diagnosed 6 months back. He was known case of myocardial infarction. He was diagnosed 3 years back, undergone PTCA. He has a strong family history for myocardial infarction, hypertension as well as diabetes. He is heavy smoker for 30 years and has quit smoking just 3 years back when he was diagnosed with myocardial infarction. Salient features on examination were he was obese with BMI of 30.7, blood pressure of 140 by 90 mm of Hg, and has severe signs of insulin resistance with grade 3 acanthosis nigricans and skin tags. Important laboratory investigations which were suggestive were HbA1c of 8.4, LDL of 137, HDL of 37, triglyceride 156, and EGFR of 65. He was on drugs. He was on metformin 1 gram BD for diabetes. For hypertension, he was on telmisartan 40 mg OD and amlodipine 5 mg OD. And for heart, he was already on atorvastatin 10 mg, clopidogrel 75 mg, and aspirin 75 mg. So main thing in this case scenario, if you can see, and the main thing are uncontrolled diabetes, EGFR of 65, obese of BMI of 30.7, and already has a myocardial infarction. So these are all the aspects, and we should always look for all these aspects in each and every diabetes patient. So what can be the patient-centric approach to management in this patient? So main thing we have to look after is first and foremost is CV protection. He already has a myocardial infarction and we don't want another attack to happen. So what all aspects we have to control that CV protection? And then next we should consider is microvascular protection. Beyond glycemic control, we should also look after the microvascular part, and that is look after the kidney. EGFR is already compromised at 65. We should also look for the neuropathy and the ophthalmopathy. We should look for the eye examination and should just do a tuning fork test to look for the neuropathy, or VPT can be done. We should also aim for weight reduction. And most important part, we should also avoid hypoglycemia in this case, as a patient is already a known case of heart disease, and hypoglycemia is already shown to increase the CV mortality if it is occurring, and that might be more harmful than the hyperglycemia in such patients. So these all things should be always looked after before treating this case. So which drug can be the best in this case scenario? So coming to this case scenario particularly, the patient is already on metformin 1 gram BD, and we have multiple options available. We have glimepiride, we have pioglitazone, meglitinides in the form of repaglinide, or alpha glucosidase inhibitors, pioglitazone, or there could be SGLT2 inhibitors, GLP-1 analogs, DPP4 inhibitor. There are multiple options which are available. What would be the best combination or the best drug? So according to me, I think adding a SGLT2 inhibitor is the best thing which we can do. And if we have, because HbA1c is quite high, we should also combine any other drug which can be added. Oral drug, if patient is preferable on an injectable, it could be a GLP-1. But if the patient want a oral combination, we can also add a DPP4 combination. So we have a combination available, SGLT2 DPP4 combination, which we can offer to this patient, and I have offered this to the patient. So what all things which can be done and can be useful with this combination is that this combination has a cardiorenal protection. This combination of SGLT2 with DPP4 has shown to have weight loss. Plus there is good amount of glycemic control also. It has shown to reduce HbA1c by more than 1.8% if A1C is more than 8.5, or more than 1.3% if A1C is less than 8.5. So in this case, we can achieve HbA1c reduction of more than 1% with this combination, achieving our target A1C of around 7. Plus, both these drugs will have less propensity to cause hypoglycemia. So this is what we want in this case. So this is the next combination which we can consider. Coming to the cardiovascular disease which the patient is suffering from, we all know that type 2 diabetes, most common cause of mortality in type 2 diabetes is cardiovascular disease. So mainly the patient dies from cardiovascular disease. Next is the heart failure, and only after that comes the kidney and other issues. So cardiovascular protection is the most important part which should be looked after. It generally occurred 12 to 15 years earlier in the people with type 2 diabetes. Framingham offspring studies has already shown that type 2 diabetes patient, 2/3 of them already have a subclinical cardiovascular disease. That means they don't have any symptoms or signs, but they are suffering from cardiovascular disease, and that is quite a big number. 66% of them are already suffering from some amount of cardiovascular disease, and that's how it was. Type 2 diabetes is always considered as a cardiovascular disease equivalent and should be treated accordingly. Plus, diabetes has also shown in the Framingham offspring study that diabetes increases the risk of cardiovascular disease by 4.2-fold. So that is also quite a good amount of increase in the cardiovascular disease. Plus, if there are multiple risk factors, again, this thing has to be handled, like smoking, hypertension, dyslipidemia, sedentary lifestyle. Other risk factors should also be handled in the diabetic patient, other than controlling only the glycemic part. Coming to a drug combination, SGLT2 as well as DPP4 inhibitor. Coming to the SGLT2 per se, there came a landmark trial for empagliflozin SGLT2 inhibitor in 2015, EMPA-REG outcome study, which has changed the treatment protocol in the diabetic patients. This was the first drug which has shown not only cardiovascular safety, but has also shown that it has good amount of cardiovascular mortality benefit as well as major adverse cardiovascular event benefit. So this was the first drug which has shown cardio protection. Other drugs which are available has all shown that it is just cardiac safe and not protective. So this has actually changed the treatment protocol in diabetic patient. It has also shown that there is decreased amount of hospitalization to heart failure. Plus, there is also decrease in the CKD progression as well as albuminuria progression. So all these benefits were seen in the empagliflozin arm as compared to placebo, and this is all independent of the glycemic part, which empagliflozin is doing. So mechanism postulated to that is independent of glycemic control, as I said. Have been postulated main mechanism is that it inhibits sodium hydrogen exchanger pump in the cardiac myocyte, which increases the sodium ion in the mitochondria, which can reverse the electrolyte disorder in the patient with heart failure. There's another mechanism postulated is decrease in the oxidative stress. Plus, another mechanism which is postulated directly is it increases the ketone bodies in the body. And ketone bodies, it has also shown to have increased amount of decay, especially in the lean, thin elderlies, as well as type 1 diabetics if it is given. Also, if patient is surgical or hospitalized, there's risk of decay and should not be prescribed in this setting. But this ketone body, on the other hand, if increased, has shown multiple benefits in the body of type 2 diabetes. It has not only shown cardiovascular protective, it has also shown atherosclerosis, protection in the atherosclerosis. How it has shown is ketone, if increased, they have an inhibitory effect on NLRP3 inflammasome, which is bad for body. And if this get inhibited, it has multiple benefits. So these are the direct mechanisms by which SGLT2 is causing improvement in the heart muscles as well as heart failure, as well as decreasing in the cardiac mortality. There can be indirect mechanism also, which we always think of, like decrease in the BP, decrease in the weight, less hypoglycemias, and a good amount of glycemic control, which is shown with the SGLT2 inhibitor. So after this study, there also came a EMPA heart study, which has also shown a similar results, and how it is causing, they have shown by a cardiac MRI image also that there is a decrease in the significant reduction in the LV mass regression and reversal of cardiac remodeling. So this is the independent mechanism which EMPA heart study has also shown that this thing is proven. And now multiple studies are also coming for EMPEROR reduced trial for heart failure with reduced ejection fraction, as well as Emperor preserved trial for heart failure for preserved ejection fraction. So reduced ejection fraction has already shown that patients who are not diabetic also, they have also shown to have reduced in the hospitalization to heart failure as well as reduction in the cardiac mortality. So even guidelines might come that in non-diabetic patient also empagliflozin might be given if they are suffering from heart failure with reduced ejection fraction. So this is this for those guidelines we have to wait further. But overall, now we for diabetic patient, of course, we have a wonderful drug in the form of empagliflozin, which will always be given, and ADA always recommend that if the patient is suffering from atherosclerotic cardiovascular disease or CKD, we should always consider, independent of HbA1c, we should always consider a GLP-1 analog with proven cardiovascular benefit or a SGLT2 inhibitor with proven cardiovascular benefit, which empagliflozin and EMPA-REG trial has already shown. Coming to the DPP-4 inhibitor combination of empagliflozin, which I was suggesting to this patient, was another was linagliptin, which is a good potent DPP-4 inhibitor, has shown a good glycemic control with less side effects and has also shown CV and renal safety in more than 15,000 patients in Carmelina and Carolina trial. Other DPP-4 inhibitor had not shown much of cardiac safety. The available drugs which are vildagliptin has no CVOT trial. Other drugs which are available is teneligliptin has shown no CVOT trial, and they have shown to have increased QT interval also teneligliptin. Sitagliptin overall is safe and has shown CV safety also, but sitagliptin combination is not available with empagliflozin or other drug. Only available combination with sitagliptin is with saxagliptin, and saxagliptin is shown to have increased heart failure, so this combination should be prevented. Overall, if we see to this combination, if you are giving this combination, it has very good compliance, EMPA plus linagliptin. It can be given together to increase the compliance of the patient. One more meta-analysis has also shown that if you are combining this DPP-4 inhibitor with SGLT2, the amount of incidence of genital infection decreases. And hypothesis for this thing given was that DPP-4 enzyme is present in the bacteria which are causing genital infection, and these bacteria or fungal infections, they might be inhibited because of the inhibition of this DPP-4 enzyme. Their growth might be inhibited and they might have less of genital infection. So overall, there is also less side effect profile if you are giving this combination. Plus other beneficial role is there is less amount of hypoglycemia with good amount of glycemic control, more than 1% reduction of HbA1c, plus weight loss. So overall, if you see, the combination of EMPA plus Lina is a very good option for such patients, especially who are with high CV risk and renal risk. So to conclude, I would just like to emphasize that each and every diabetic patient, we should not only look after the glycemic part, we should always look after the other complication parts which are happening to that patient. We should always rule out nephropathy, neuropathy, ophthalmopathy, and should rule out any heart issues if the patient is having, and we should target or NAFLD, and we should target those things also, because these are the things which is causing the death of the patient and not only the sugar part. So we should always consider, especially in this case when patient is having CV and renal risk, we should always consider a GLP-1 or SGLT2. Thank you. I will conclude the case with this saying. Thank you very much.